Good afternoon. Thanks for joining us. I'm Jerry Vockley, and I am the Chief of Medical Genetics and the Director of the Center for Rare Disease Therapy at the Children's Hospital of Pittsburgh. And today we're going to talk about PKU, modern therapies for an old disease. PKU is one of the earliest recognized inborn errors of metabolism, and it affects the metabolism of the amino acid phenylalanine. It's a recessive disorder. That means both parents are carriers for the disease, and when by chance they both pass on their copy of a gene that doesn't work, the child is affected. So if parents are known carriers, their risk of having a child with PKU is 25%. The gene involved in PKU is the gene for the enzyme phenylalanine hydroxylase. It's located on chromosome 12, and mutations or changes in the genetic material for this gene that inactivate the protein, the enzyme phenylalanine hydroxylase, lead to PKU. As I mentioned, it's one of the most common disorders that we see, and across the world, its incidence is about 1 in 10 to 1 in 15,000, though it increases and decreases in specific ethnic populations. The early patients recognized with PKU prior to newborn screening had a very devastating disorder with very bad neurologic symptoms, almost no intellectual development, and a very difficult to control clinical picture. The introduction of newborn screening now over 50 years ago in the United States, and now followed by many developed countries around the world, has really changed that clinical picture. It's allowed us to identify the disease before the onset of symptoms and then institute a treatment, usually within the first week or two of life. This slide just shows the biochemical problem in PKU. Phenylalanine, an amino acid, one of the building blocks of proteins, is turned by this enzyme, phenylalanine hydroxylase, into tyrosine. When you have a defect in PAH, the phenylalanine increases in the blood and the tyrosine decreases. This enzyme is only present in the liver, and so the damage caused by the phenylalanine is strictly because of the accumulation of it in the bloodstream and the toxic effect on other tissues. So if we can get the phenylalanine down in the blood, we can reduce or eliminate the symptoms related to it. The disorder is called phenylketonuria, or PKU, because phenylalanine in increased amounts in the blood is acted on by another enzyme. It's turned into this compound called phenylpyruvic acid. That's what accumulates, one of the things that accumulates in urine, and was originally identified and gives the name of this disease. Now, I mentioned that the buildup of phenylalanine is what causes symptoms, and let's look at that for a minute. If all of the Phe in the body is metabolized here in the liver, in PKU, that phenylalanine goes up and it comes out of the liver into the bloodstream, and it goes to all of the tissues. It doesn't seem to cause any damage in any other tissue but the brain. To get into the brain, it has to cross what's called the blood-brain barrier, and it uses a specialized protein that transfers it from here in the bloodstream here into the brain, called the LAT1 transporter, the LAT1 transporter. And the effects on the brain are broad, but the reason that they cause problems is still not completely understood. It can affect a number of different functions in the brain, including the functioning of neurotransmitters, one of them called glutamine. It affects the enzyme activity of some other enzymes that can have secondary effects. All of this can damage an important component in the brain called myelin, and then it also inhibits the metabolism of tyrosine and tryptophan, two other amino acids in the brain, and these are important components to the neurotransmitters in the brain. So overall in the brain, you have a series of events that, if left untreated, lead to cognitive defects and significant neuropsychological dysfunction. We'll talk about treatment with large neutral amino acids a little bit later, but I just want to point out to you that they work at the level here of the blood-brain barrier to some extent, and this LAT1 transporter is important in that process. Now, by controlling the Phe intake in the diet, can reduce the blood Phe level to essentially normal, as much as we need to restrict the phenylalanine. What that does is avoids the biggest effects, that early dramatic brain damage that was seen in the original patients who were untreated early. However, even treated, we now recognize that there's a spectrum of neuropsychiatric problems that can present in PKU. We'll talk about the reasons for that in a second. One of the classic findings is something called an executive function deficit. Executive function is that ability to sort of sit down and plan complex tasks. So when you start your day, you think, I have to wake up, I have to get my breakfast, I have to get dressed, I have to get in the car, I have to get to work. When I get to work, I have to log into my computer. You've got a series of multiple things that you have to do. And if you have a deficit in executive function, depending on how severe that is, you break that ability to sequence things. And so instead of getting up out of bed and getting breakfast and getting dressed, you get distracted and turn the TV on and watch the news, and suddenly you're late for work and you can't remember your password to log into the computer. That's an executive function deficit. There are also a variety of neuropsychiatric symptoms. Depression and anxiety are very much increased in patients, especially who have been off of their treatment for a period of time. And from the behavioral standpoint, attention deficit disorder is really the most common thing that we see, along with some other things that are listed here that are less common. And then finally, especially in patients who are off therapy, we see neurologic changes that include things like spasticity. You may have noticed, if you have PKU, that your reflexes are very brisk. That's kind of the earliest or the basic thing that we see in everybody, and is kind of like a precursor to spasticity. Tremor, the ability to keep your hands still, gait disturbances, and seizures, although they're not a common finding due to phenylalanine intoxication itself, appear to be increased in frequency in patients with PKU. This is a real problem in individuals even treated early, and what you can see in a recent review by Dr. Bilder at the University of Utah is that the rate of intellectual disability is higher in patients with individuals with PKU, and these are early patients identified by newborn screening compared to the general population, 5% compared to less than 1. Anxiety, which I mentioned, is a very common problem, and depression is a very common problem, higher by 50% and almost double respectively compared to the general population. The good news is that if your Phe is out of control and you have any of these variety of neuropsychological problems, they are decreased by lowering your Phe. So here you can see in each of these cases, the dark box is off with high Phe, and the light box is with low Phe, and for the most part, they're all lower when your Phe is under control, and so this is really led to a recognition of the Phe for life that I'm sure most of you out there who are dealing with PKU have discussed with your care providers. It's been the standard of care for at least 30 years, if not longer. One of the completely unexpected aspects of identifying PKU with newborn screening and treating it early was the development of a maternal PKU, and this has nothing to do with symptoms in the pregnant mom with PKU, but in their babies. May recall that in the early days of treating PKU, we tended to tell patients they could come off of their Phe when they were, first it was 6, and then it was 12, and then it was 18, and now of course we say not at all. But in women whose Phe levels were out of control as a result of that transition, when they got pregnant, their babies who don't have PKU by definition, mom's passing on a PKU gene and dad is not, so the baby's just a carrier. However, they had babies had a very high incidence of microcephaly, heart problems, and then as they grew older, developmental problems. And moms in this setting also had an increased rate of pregnancy loss. So something that we would never have known about had we not started treating PKU early, and now is a major factor in trying to make sure that we get at least women of childbearing age under good Phe control. In recognition of all of these issues, the American College of Medical Genetics back in 2014 convened a group of specialists and put together treatment guidelines. And while those treatment guidelines had a lot of information in them, the key thing is that it recommends the guideline recommends a lifelong goal for all patients with control of their blood phenylalanine level in the 120 to 360 micromolar range. So that's the 2 to 6 for those of you who are used to milligrams per deciliter. And there's a whole variety of ongoing monitoring that's recommended in that guideline, but recognizing all of the neuropsychological problems that we see in our patients, the recommendation for neuropsychological testing on a regular basis in patients was made. This is one that's very difficult a lot of times to get covered by insurance, but is one that's well worth trying to fight for in the context of your care or your family members' care. That guideline, working in collaboration with the metabolic dietitians group, the GMDI, summarized recommended protein and phenylalanine intake in patients. And remember that if you can't make tyrosine out of your Phe, you also have to supplement tyrosine. And the bottom line here is that in adulthood, most individuals are closer to the bottom end of this scale, 200 to 400 milligrams of Phe rather than the top of the scale, which are really individuals with a much milder phenotype called hyperphenylalaninemia, a milder version of the condition. And of course, this level of Phe restriction is problematic to obtain on a regular diet. You essentially can't do it because it's just there's too much phenylalanine in protein to allow you to get your protein intake to be to maintain normal growth and health and still keep your Phe low. And as a result, what we see is that not surprisingly in infants and young children, almost everybody is under control. 84% here in this one study by Elena Jarecki, published in 2017. As you get older, the number or the percentage of patients who are out of control rises. The percentage of patients who are under control decrease, and this is probably artificially low because in this study they were allowing the individual clinics to define under control, and about a third of them defined under control as being higher than the 360 that was recommended by the American College of Medical Genetics, and then the other issue here that artificially lowers this the uncontrolled box and is that a good many of our adult patients with PKU sort of fall away from our therapy. They go off to college, they go to their jobs, it's just harder for them to come and see us on a regular basis, and eventually they're out there on their own with no one in particular following their diet, or at least not coming in for regular checks and not checking their Phe. Now, fortunately, because of the recognition of maternal PKU syndrome, this reverses again in women who are becoming are planning to become pregnant, and we have a much higher level of patients under control compared to out of control. So what's the problem? Well, this is hard. Dietary management of PKU is difficult. It requires modified natural protein intake and limitations of all of these high protein foods. To keep the Phe intake at the required level, and as I mentioned, to allow you to get enough protein to grow, for children to grow, adults to remain healthy, you've got to now add modified low protein foods, medical foods. Classically, those are formulas. Fortunately, there are now some very nice food products out there that are expanding the repertoire of what a medical food is, but it's still a very restricted diet. With these modified foods have either low or no Phe with that, and then a healthy amount of fat and carbohydrates, supplementation with tyrosine, with the amino acids you can't make in this condition, and all the vitamins and minerals needed to meet the daily requirement. But it is hard. This is a typical lunch. You see a nice hamburger here with a bun, some chips, and some vegetables. For an individual, some fries for an individual trying to maintain their Phe at a low level. This looks more like this. There's a bun. There's no hamburger, of course, no meat, and then there's some leftover chips and your veggies. So it's very limiting. While taste has been improving in those of us who haven't been raised on it, it still doesn't taste very good. And and that leads to a large dietary burden in patients with PKU. They have if their Phe levels haven't been controlled well, or they're off their diet, there are issues relative to cognitive function that require monitoring, psychological function that can require treatment. There's the impact, of course, on family life, social functioning, where children in school have to come in with a special diet, and not to mention the expense of all of these specialized medical foods. And it's just hard to do it right. The best intentioned individuals can maintain their Phe, but it's difficult. And for most individuals, this motivation to get that Phe down low is often just not enough. It's the real life intervenes. It's too hard to stay on those diets, and it's very even though individuals, as with a lot of folks who try to diet to lose weight, it's easy to have ups and downs that are suboptimal. Fortunately, things are changing. And while most of what we had up till now has been diet-based, we're now seeing the development of medications that can directly address lowering the Phe and not having to with the ultimate goal of being able to have a normal Phe on a normal diet. So I'm going to talk to you about two different groups of therapies, those that are currently approved and those that are in clinical trials. Let's talk for a minute about the ones that are approved for therapy. Large neutral amino acids are not sold as a drug in the United States. They are a dietary supplement. And remember, I mentioned that they work at that transporter. And it probably has two effects. These are the large neutral amino acids. And basically, well, you can think about it as competing for that transporter that's going to import the phenylalanine that you eat in your diet, because it's in the intestinal tract as well, and the phenylalanine that's trying to get from the blood into the brain. And if you have more large neutral amino acids in your bloodstream or in your diet, you won't absorb as much, and as much won't get into the brain. This has been around for a long time. The problem is that for the most part, it's limited to use in older patients because it hasn't been tested rigorously in younger individuals. And the concern is that in the developing brain, this imbalance of large neutral amino acids might cause problems. And we also don't, for the same reason, use it in pregnant women, because we don't know the effect of the brain on the developing brain in the fetus. The other concern is that while it can lower the Phe level to some extent, it doesn't tend to improve. I'm sorry, I'm saying that backwards. While it can improve the neuropsych findings in patients to a small degree, a diet supplemented in large neutral amino acids doesn't tend to be very much lower. Patients tend to be very much lower than when they're on the large neutral amino acids. So here, with diet plus neutral amino acids, minus them, off of diet with large neutral amino acids and without. So it seems to help with some of the symptoms that are related to the brain metabolism, but it's not doing what we would like to have it do in reducing the bloodstream. Most formulas historically have been made up by the addition of the individual amino acids that you need to make your proteins, and then either leaving out the phenylalanine so you can eat a little bit in your diet, or for babies who are just drinking formula, it's low Phe. There are a lot of problems with those amino acid formulas, and so there's long been a recognition that natural protein is biologically superior to amino acids in the diet, the early part of the 2000s, it was recognized that there was a byproduct of cheese making called glycomacropeptide, and it's the end of the casein, one of the common milk proteins. That not too surprisingly, this was developed by the Wisconsin groups and Dr. Ney. Well, this piece of protein that's naturally identified or naturally produced in the whey from whey in cheese making doesn't have any phenylalanine in it. And so it was thought that this might be a good source of protein to add to formulas instead of large neutral amino acids. Now you can see while the Phe is theoretically 0 in this piece of a protein, because you have to purify it from this gamish that's here on the production line, it has a little bit of Phe in it. So you just have to work with your dietitian to know how much of it you're supposed to take. Now, the good news about it is that it appears to be, in terms of Phe control, very similar to the individual amino acid formulas. So it doesn't appear to be any better, but it's no worse. And the good thing about it is that it has the improved biological benefits of having a peptide, a small protein, instead of individual amino acids, and it has less taste masking that has to be done to get rid of the flavor of some of the individual amino acids, and so a lot of people think that it tastes better and it's than the individual amino acid formulas, and so it's being incorporated into a lot of newer formulas. While those are dietary options to try to improve the diet while maintaining low Phe intake, there are now 2 drugs that have been approved by the FDA for treatment of PKU: sapropterin, or Kuvan, and pegvaliase, or PegPal, or Palynziq. This one's been approved now for about a dozen years, and we have a lot of experience with it. This one only approved last year after quite an extensive experience with it in clinical trials. Kuvan, or sapropterin, is a form of biopterin, which is a key component of this phenylalanine hydroxylase enzyme. It's necessary for proper folding of the immature protein to the mature form to make it active, and it's also necessary for the enzyme to do its chemical reaction. And it turns out that many individuals with PKU, if they're supplemented with extra biopterin, or in the form of Kuvan or sapropterin, are able to make a little bit more protein, or it's able to be a little bit more active, or both, and can lower their phenylalanine levels by just taking this powder or these capsules. Somewhere between 1.25% of patients with PKU due to PAH deficiency have some response to sapropterin. If you have a mild version of the disease, you're much more likely to respond than if you have a severe form of it. And if your PKU doctor has checked the mutations that you have causing your PKU, they can tell you whether or not you have any protein at all. And if you have no protein at all, then the sapropterin is not going to work. If you have some, then there's a chance that it's going to work. Overall, I usually say to patients that about half of patients respond, and about half of, and then those who respond drop their Phe levels by somewhere between a third and half. So it's not a cure, but if it drops your Phe and allows you to eat a little bit more protein in your natural protein in your diet, it has some benefit for you. There's been a lot of work looking at whether this lowering of Phe translates into an improvement with some of the neuropsych problems that are associated with especially untreated PKU or individuals who have been early treatment but have come off their therapy. And what this graph shows is that here in a scale of attention deficit disorder, where low is good and high is bad, individuals on sapropterin for as long as about half a year improved relative to in the first half of that treatment. They were treated with sapropterin for 13 weeks. They improved, and then everybody caught up over the course of the next year when everybody switched, when the folks who were treated with a placebo came on. So it looks like there is a neuropsychiatric improvement that is associated with reducing the Phe. And there are some individuals whose Phe doesn't change very much, but yet say they're better, they feel better when they're on the sapropterin. Nevertheless, it's not that magic bullet. It doesn't make everybody have a normal Phe on a normal diet. This brings us to pegvaliase. Pegvaliase is an enzyme. It's phenylalanine ammonia lyase. And this is not the same enzyme that's deficient. Remember, it's phenylalanine hydroxylase in PKU, but it's an enzyme that can metabolize Phe and turn it into a compound that is non-toxic. If you just injected this into an animal, an individual, it would be gone very, very quickly, and it wouldn't have any efficacy. And so there's a lot of experience in the pharmaceutical industry of covering this with a molecule called polyethylene glycol. And this molecule sort of hides the protein from the immune system, so it sticks around for a lot longer and prevents it from being degraded in the bloodstream. So the good news about pegvaliase is that it unequivocally works. So you can see here in a large group of patients in the clinical trials over the course of 24 months that the study group started off with an average Phe of just over 1,200, and when they were done, they were down here pretty close to the target range of 360. It was about 400, it improved over time. So at 6 months, you can see the spread between or among those who are at 600, 360, and 120. That increased over by 12 months, and at 24 months, it increased even more. That translates into an improvement in symptoms. Here, an ADHD scale, again, lower is better versus phenylalanine. And individuals who started off in this group, the Phe level was about 1360, started on pegvaliase. Their Phes dropped. Then they were changed. They were switched over to a placebo to prove that in fact it was the pegvaliase that dropped the Phe. Of course, it went back up. And then they were started back on the pegvaliase, and it lowered again. And in the ADHD scale, it dropped when the Phe dropped. It stabilized when the Phe went back up a little bit, and then it stayed at that level or a little bit lower over the duration of this. This was 49 weeks. So the cognitive effect, the neurocognitive effect, was long-standing. So this is what we want, right? This is these patients, by virtue of having Phe levels at over 1,300, were essentially on unrestricted diets. They had come off their dietary therapy, and now they were getting down here to not quite normal, but within a range that is where we want them to be. There are some concerns or some issues in starting pegvaliase treatment. There's a relatively high immune response to that PEG, that polyethylene glycol, that leads to some symptoms in the early going that tend to drop off. These are the antibodies are high. This is actually antibody titer, and it drops off with time. And so the hypersensitivity reactions, the allergic reactions, also tend to be highest in the early going and drop off later on. And it's probably this immune response that also takes for a while for the treatment to kick in. The other issue is that these are most individuals are either on 20 or 40 milligrams of this drug, and that corresponds to 1 or 2 injections of 2 mLs every day. So it's not a trivial treatment, not everybody wants to do that, is able to do that, is comfortable doing that. So while this is reaches our goal of the ability to have a normal Phe level on a normal diet, it would be nice to have alternatives for other options. Just to mention to you that of course, if you take this drug and your Phe normalizes, that's great, but don't think you can stop going back to your PKU docs. You shouldn't. You require monitoring for this. We still want to follow your Phe levels, and we still want to make sure that you're doing normal, doing well on your diet. So what about those options? If pegvaliase is not for you, if sapropterin and Kuvan doesn't work for you, or it doesn't normalize your Phe, and you're still struggling to keep your Phe under control, what else might be out there? Well, fortunately, a lot is coming down the pike, and we're going to talk about some of those coming attractions in the form of clinical trials. And I'm going to break them down into 3 big categories. And we'll talk about them each in turn. These are therapies that involve manipulating the gene or the message for the enzyme PAH enzyme. Those are the nucleic acid therapies. Therapies designed to give you cells back that have PAH activity, might be an option for some. And then more traditional drugs that like Kuvan that might work to improve the treatment of PKU. To orient you, I'm going to go back to something that you may or you may not remember from your high school biology, or if you're not quite up to that, go to a biology book and take a quick look at this. Remember that the information for making all of the proteins in your body, including phenylalanine hydroxylase, is contained in your genes. And your genes are in every cell, and every time a cell divides, so you start as a single cell fertilized egg, and you divide, that divides to be a baby, and as a baby it divides to be you divide until you grow to adult, and then as an adult it divides to replenish cells that die off over time. Every time a cell is made, you have to make new copies of the DNA. That's called DNA replication. But the information that's on those genes doesn't get directly read into or turned into proteins. There's an intermediate step called transcription, and DNA is used to make another copy of that information called RNA, or messenger RNA. and that's what makes the proteins. There's an in-between step here. It turns out there's a lot of extra information in the genes, and when it's first transcribed, that's when you first make this RNA, you got to get rid of that extra information called the introns and put the exons together. That's where the protein information is, so that now the machinery in the cells that makes the protein, a process called translation, can occur. And we can, in the context of nucleic acid therapies, theoretically intercept the process and try to fix it at any one of these levels. So let's work backwards. Let's start at the message level. So if you have a message that's made from a gene that has a change that inactivates it, a mutation, if we give you message, then you should be able, a normal message, you should be able to make that RNA. So I'm just going to show you here a couple of examples of this. This is not for PKU, but this is for a couple of other disorders that we work on. Here, a disorder named after the enzyme, very long chain acyl-CoA dehydrogenase, or VLCAD. This is an experiment in a VLCAD deficient animal, a mouse, where the enzyme activity is very, very low, essentially undetectable in this animal. And if you give increasing amounts of mRNA to this animal, you can get it up to almost the normal range. Here shown as protein, where the mouse makes no VLCAD, and as we increase the dose, here it comes close to the wild type level. There's a study that's going on for another disease called methylmalonic acidemia, or MMA, where the company that makes both of these products, called Moderna, gave a message, a therapeutic mRNA to the mouse, and nearly normalized the level of MMA in their blood. You can see here that it drops down to very, very low. And so this is a drug that's in clinical trials right now for MMA. This therapy, in theory, would work for PKU, because remember I said it's the metabolism for that is purely in the liver. We can give this therapeutic RNA through a single injection, typically 2 or 3 times a week in these other diseases, and normalize things. So this is a potential way to get the enzyme into your liver, make a lot of it, and let your liver detoxify the phenylalanine, rather than having the enzyme floating around in your bloodstream as with pegvaliase. The advantage to this is that you probably only have to do it every 2-3 weeks, and the allergic reactions are going to be way smaller, because the drug's not in the bloodstream, or the enzyme's not in the bloodstream, it's in the liver cells. Right now, there is not a clinical trial for this. There are at least a couple of companies that are looking to develop it, and I suspect that sometime in the next year or two we'll see this come down the pike. We go back up to the top of that pathway that I showed you. Where we're talking about the genes, and so we come to gene therapy. This is what everybody's been waiting for the last 30 years. For the last 30 years, geneticists have been saying, oh, gene therapy is just 5 years down the road, and it never was. Now it is. Gene therapy takes a normal gene, or normal protein coding sequences for the phenylalanine hydroxylase gene, puts it into what's called a vector, a vehicle to deliver it to in the bloodstream to the liver, and then lets the liver, much as I said with the therapeutic mRNA, lets the liver make the messenger RNA, and the messenger RNA can now make protein. And I say that it's no longer 5 years down the road, because a company, Homology, has shown, first of all, that they can cure PKU in a mouse. We've actually been able to do that for a long time. A couple of groups, including Dr. Harding in Oregon, have been able to show that if you give enough gene therapy dose, you can start reducing the phenylalanine level. But if you give it a high enough dose, it'll hang around and cure that mouse for the life of that animal. This gene therapy vector, now made by Homology, is in clinical trials. There are a number of sites across the United States, including here in Pittsburgh, who are enrolling patients. And if you are interested in it, for starting, you need to be over 18, there are other entry requirements that you can learn about by talking to your local site. There's also funding to have you travel to one of the sites if you don't happen to be terribly close to one of them. You can go to clinicaltrials.gov and look up all of the trials that I'm talking about, or you can go to the company website and look them up, or you can ask your PKU doctor. In addition to the vector developed by Homology, which is in clinical trials right now, there's another one being developed by BioMarin, our friends that have made Kuvan and pegvaliase. They also have a gene therapy vector. We are enrolling in a study that will allow us to identify patients over the next 6 to 12 months who would be eligible for gene therapy, with the hope to start delivering actual gene therapy in the coming year, in 2020, probably mid-year. And BioMarin, I'm sorry if I forget the exact time that will happen, but it'll sometime be mid to late 2020. So again, talk to your PKU docs. Or go to clinicaltrials.gov and you'll be able to look those up. There are a couple of other companies that have said they're developing vectors. They're not close to clinical trials yet, but there's a lot out there that will be available. The glitch with gene therapy is that the vectors, the vehicles that are used to deliver these genes, are made from naturally occurring viruses, and you may have been exposed to one of these viruses over your lifespan, and you may be resistant to it. This is why it's nice to have multiple gene therapy vectors out there, because there's a good chance that if there are 3 or 4 options, you will not be immune to all of them. And so if you go to the Homology study, which is open now, and you turn out to be allergic to the vector that is made from, there'll be other things coming down the pike. I should mention that a lot of folks know about problems that developed in the gene therapy almost 15 years ago now, I can't remember exactly when, with a patient who died with gene therapy. And I'll let you know that this is very different technology. That virus is no longer being used, and while no experimental therapy is without risks, we think that the risk for this happening is extremely low, and there's no reason to expect that it will actually even happen. There's another way of delivering genes. If all of your phenylalanine hydroxylase is in your liver, and you had a liver transplant, you would cure your PKU. This has actually been done, not to cure the PKU, but for individuals who have PKU and developed another liver disease that required a transplant. Sure enough, they got the transplant and their PKU was cured. Now, it's still theoretically possible to get a liver transplant for PKU. We have a protocol here at Children's to consider that. We view it as a last resort for individuals who can't control their PKU any other way, and are very symptomatic, or are having having problems that are related to that. And so if you're interested in that, go to clinicaltrials.gov and you can look that up. No, I'm sorry, that's not on clinicaltrials.gov, but because it's not a clinical trial, but you can look at the Center for Rare Disease Therapy right down here. Just Google that at Children's Hospital, and the staff there can give you that information. However, we have another option because we have technology that allows us to isolate the liver cells and actually transplant that instead of giving the whole liver, and that's done by a very clever technique by isolating the liver cells in the laboratory, and then we can infuse them through the vein that goes from your belly button to your liver. This is the vein that used to connect you to your mother. And we used to think it's closed off in infancy and childhood. Well, it turns out you can tease it open, and you can infuse cells there. And in the one patient that we've treated thus far, we were able to significantly reduce the phenylalanine in that patient from well over 20 milligrams per deciliter, or about 1,400 micromolar, down to 700 micromolar, or 14. So not quite in the therapeutic range, but getting there. This was a very early attempt, and we now know that we can deliver more liver cells to patients. So while this sounds like a drastic procedure, it's actually quite simple. This is just like getting a blood transfusion. It does involve immunosuppression, but the immunosuppression is very, very mild, and it's no more than what patients are taking for relatively common diseases like arthritis. So if you're interested in this, back to my clinicaltrials.gov, and you can get the information there, or you can get it from our Center for Rare Disease Therapy. Let's see, I appear to be stuck. Let's get out of here for a second, go to the next one, and see if we can pick it back up again. Another cellular therapy is from a company called Rubius. Oh, I got that spelled wrong. It's Rubius. It's just U. There's no O in there. Sorry about that. They have figured out a way of making red blood cells grown from stem cells to produce high levels of our old friend PAL, the phenylalanine ammonia lyase. The red blood cells can then be given to you, and because phenylalanine can get in and out of red blood cells very easily, the red blood cells will chew up the phenylalanine. This is in clinical trials. The expectation is that the dosing will probably be once every couple of months. Natural red blood cell lives a little bit longer than that, but this is like a blood transfusion almost, so the blood cells are a little bit shorter lived. But like delivering the mRNA to the liver, this is a longer acting form of the drug, and because it's inside a cell, it will have lower levels of immune response compared to pegvalase. This is the trial. It's designed. It's in the phase 1 trial. We're really looking at safety and tolerability and doing some dose escalation. And then after this cohort is enrolled and the trial is finished, we'll move to whatever looks like the optimum dose and the clinical trial. There's another version of phenylalanine ammonia lyase that's designed to be taken orally. This is a new technology by a company called Codexis that's being put into clinical trials by Nestle. Yep, that's the same company that makes those chocolate bars. They have a pharmaceutical arm, and they have this phenylalanine ammonia lyase that can be ingested and in the intestine, it will chew off that ammonia group and make turn the Phe into a non-toxic compound called tranexamic acid. So this is designed to chew up the phenylalanine in the intestine and digest it before you can even absorb it from your intestine. Another way of doing that is to build the phenylalanine ammonia lyase enzyme into a probiotic organism. This is being done by a company called Neurologic, and we recently presented our phase 1 data for this drug at the metabolic meeting in Europe. This was a first in human study, so a phase 1 really looking at safety and tolerability. And what we were able to show was that the molecule worked. If you take this organism, it's a daily dose. That is it's called an E. coli missile, and it's what you get in a probiotic capsule if you go to Rite Aid and just buy a probiotic and take that. But it's been engineered to have this enzyme in it. You can see that the metabolites that are related to having this enzyme increase with an increasing in the dose, this is in blood and this is in urine. So it looks like the probiotic is working, and we're now getting ready to. And the phase 1 trial is over. We're getting ready to enter a phase 2 trial. So for both the red blood cell therapy, the Nestle drug, and this Neurologic drug, go to our old clinicaltrials.gov, and you can find the center closest to you. And as with most of these, we're an active center here. Would be happy to talk to you about and enrolling. Neurologic has done some modeling on this probiotic, and they figure that they can lower the phenylalanine in your blood by 50% on a normal diet at optimum dose with this drug. Potentially usable in combination with other things that drop the Phe a little bit, and might be able to get you down to the therapeutic level without using one of the other gene therapy approaches or mRNA therapy or injectables if you don't like those. One of the problems that we've had forever in treating patients with PKU is that we don't have the equivalent of a home glucometer. Diabetics can measure their glucose level at home anytime they want. We've been partnering with a company called Apotek to develop this kind of meter. This is what it looks like. This is about this big. This tall, so it's a nice compact unit. It's not handheld yet, but it integrates with your iPhone or a iPhone, and you take a little prick of a little finger prick. Instead of putting it on a filter paper, you put it in this little cartridge. The cartridge hums for 10 minutes, and it tells you what your I think it's down to 5 minutes, and it tells you what your Phe level is. So you can measure your Phe at any time. It's got very nice characteristics. It corresponds very nicely with the Phe measured in a biochemical laboratory. We're getting ready to do a clinical trial with this 6-month randomized trial. 3 months on the meter, 3 months without it, cross over and see if you do better with the meter than without it. Yep, go to clinicaltrials.gov and you'll get the information on that. I think it's just Boston and Pittsburgh doing that trial. Finally, just as an aside, because the mice with PKU don't seem to be a real good model for the disease, for studying the disease in humans, we've been looking at making a model in a larger animal, here a pig. Why a pig? Well, their brain's a lot more like a human the mouse's brain, and they're very behaviorally very complex. So we're doing that, and we've already made it. This is the Pku pig. This is her sister, this pig has Phe levels up to 5,000 micromolar. That's 3 times higher than we get in people. So we think it's going to be a good model to test. She is not devastated, neurologically devastated, as untreated patients are, humans. So it's not quite the model that we would see, but we now have one litter of pigs from this animal, and we're studying mom. We're studying the piglets to look at the effect of the Phe on them. So in summary, you can see that at this point there are a lot of companies who are now making or anticipating trials in phenylalanine or to treat hyper-Phe and PKU. Some of these actually need to. I've got to move them over because we're in phase 1 now, and it crosses the gamut of different therapies. The approach to treatment is going to look much different 5 and 10 years from now than it does now. Even with 2 relatively effective drugs, there'll be lots more options. So I'm going to stop there. Thank you for listening to you. This is our lovely Children's Medical Center here in Pittsburgh, and I hope you have the opportunity to come see us for one of these clinical trials. And I'm going to be able to take questions from folks out there. If you use the ask a question function on the web browser that you've logged into this, used to log into this webinar, that'll go to one of our industrious CRDT staff who will refer those into me, and we'll try to offer them. Let me warn you that I can't be specific about your question for yourself or your family member. All of these answers come with the caveat that the best person to talk to you about your PKU is your PKU doc. So I'm happy to answer sort of general questions about any of these therapies and go from there. Now I had one question come in by email earlier, because the individual wasn't going to be able to be on the webinar, and asked if she could ask it in advance, and sure, I'm glad to try to give it a quick answer for you. And this was a mom of a patient with PKU who is now an adult out in the world, but still having some of the neuropsych issues that we talked about, anxiety and depression, and just wanted some more information on peg-valiase. So I hope that my earlier comments were useful for you. Peg-valiase can lower Phe to normal levels on a normal diet, and is now available commercially. So you can talk to your PKU doc, and if you want to, if your son wants to give that a try, that's the place to go. And let's see. I was perfectly clear and there are no questions. I'm happy to wrap it up. I'll give you another 30 seconds to finish your typing if you are. Oh, they're trying to send them to me. So we got a technology glitch here. They are not showing up on my screen. Let's see what happens. While we're waiting for some of those questions to come through, I can maybe talk to you a little bit more about.
Oh shit! That didn't help.
Well, do remember the microphone is on, as is the camera. And I can talk to you a little bit about clinical trials in general. Keep in mind that these are experimental drugs, and so by definition, we don't know if they're going to work. A lot of people ask about placebo controls, and they're a little afraid to sign up for a trial because they say, well, I want the thing that works. Well, we don't know if it works. And the only way we're going to know if it's going to work is if we compare it to a placebo. Most of these trials are designed so that you are randomized to a placebo to start with. And then at some point down the line, you get access to the experimental drug, and so we can both compare your response on a placebo to the folks who are on the active compound, the test drug, and then when you move from placebo to the active drug, how you did while you were on placebo compared to the active drug. This is always done in a double-blind controlled study. That means you don't know what you're on and we don't know what you're on. There's somebody out there monitoring the safety, and if they see a problem, they can tell us who's on active drug versus not. But this is to try and keep you keep everybody blinded to the study and get the best possible view of whether or not what we think is happening with this drug is happening. The best source to identify clinical trials, we think we may have it here, maybe. Okay, so we do have a few questions here. Someone who asks about having been on the clinical trials for pegvaliase and had to stop secondary to joint pain and would like to try it again. You mentioned a key part of the treatment with pegvaliase is having recognized those problems, the allergic response, including what's like a flu-like symptoms early on in the disease. And once that was recognized, we added drugs, antihistamines, and pain meds like ibuprofen to reduce those symptoms. And so the answer is yes. If you were on the clinical trial and you stopped it because of those symptoms and you hadn't been pre-treated, you're welcome to try it again clinically, and your PKU team will help you with the drugs that you should be taking for those symptoms. One thing you might want to know is that it seems like if you've ever been on pegvaliase and you stop it, you don't have that initial really bad set of flu-like symptoms that almost everybody gets in the first couple of weeks, between 2 and 3 weeks, and so you might find that it's actually easier for you to go back on the drug than when you were there the first time round. Let's see, interest in the home monitor. How far out from commercialization? The company wants to ask that too. Obviously, we'd like to get it out there quickly as possible. The clinical trial is designed to run for 2 years. We might find that it works really well, and we'll see it with a lot shorter time frame, and we'll be able to cut the trial short. But I would think of it in terms of being a couple of years off. I know that sounds like an eternity, but we've been doing this for 50 years, and hopefully we can hang out for another couple. let's see. The next question was also on the Phe meter. Are there clinical trials for children under 18? And the answer is, let me think if anything is down under 18 right now. I think everything is still over 18. All of these phase 1 trials, the FDA asks us, they demand that we do it in older patients first. However, you can keep your eye on the studies because they all very quickly drop down in age range. So there's a safety portion in the adult phase that lets us once that safety measure has been met, it gets dropped down to the lower ages fairly quickly after that. And the time frame and the exact age range is a little variable. Most of them the next age range will be sort of adolescents to, so kind of 12 to 18. And then the next range will be children in the 4 to 6 range up to that 12 range. So it's going to be, and probably that transition in most of these studies will be a couple, 3 years. So keep your eyes on it. Are there plans to test PEG-PAL in children and teens? Yes. I can't give you very many details about it because I don't know them yet. But keep an eye out for those of you who belong to NPKUA and can PKU. We'll certainly be announcing those clinical trials through there, and will hopefully be available to you soon. The question of gene therapies and how long they last is a really interesting one and an unknown. We think about the liver in adults as being a static organ, but it's not really. Somewhere between probably 10 and 20% of the liver turns over every year. And so the gene therapies, and I didn't dwell on this, but the gene therapies don't integrate into the DNA. So that step about replication that I talked about, every cell has to duplicate its DNA every time it divides to make a new one. Well, one of the cells is going to get the gene therapy vector and the other one isn't. So over time, we anticipate that the efficacy will wear off. There are gene therapy trials for other diseases that have shown efficacy for 5 to 10 years. I don't think that will be likely in PKU, but that's purely a guess. I do think we can look forward to, maybe 5 years with nothing else, maybe prolonged if we add in one of these other modalities that we're talking about. But ultimately, you most likely are going to have another therapy. And another reason to think about doing multiple vectors, multiple clinical trials, and I'm glad that there are multiple companies interested in this, because if you've had one, you can't repeat it. So then you're going to have to go to one of the others. So this will be something that's followed long-term, of course, in patients who are treated, and we'll only know the answer as time goes on. Are the 2 medicines from BioMarin the only FDA-approved ones? Yeah, right now that's it. And so work with your PKU docs to use one or both of those, and or if you're not on one of those and you want to enroll in one of the clinical trials, look into those as a possibility. Can you tell us anything about the status of urine Phe testing? It's not really something that's been terribly useful in the past. We know if your Phe level is high, your Phe level in the urine will be low. So and the clearance by the kidney is variable. So there are folks who are interested in looking at the Phe levels in urine to see if they can correlate closely enough with blood levels to be useful as a marker, so you don't have to prick yourself. You still have the problem of having to send it off to a lab until we get the Phe meter up and running. I should mention that I know of at least 3 other companies that are working on Phe meters as well. So I do think that they're going to be out there in the not too distant future. Trials open to Canadians. Boy, I'm going to have to punt that one back to your director, John Adams. He really keeps on top of all of those and can let you know which of these are open to Canadians and which of them will allow you to come to the United States for a trial, because the companies will all pay for travel to these trials. There are issues relative to availability of the drug after the trial, even if it isn't proven to be effective, that interfere with some of the entry into the Canadian market. So, John, if you're on the line, if you're on the computer, do pass that information along to your members, and if you're not, I'll email you after this. Relative to the gene therapies, the issues of being resistant to one of the to the strain. As I mentioned, these are naturally occurring viruses. They are viruses that are present in the body but don't cause any symptoms. So that's why we think they're likely to be safe. And there are dozens of versions of these, and the likelihood that you've been exposed to them all is probably small. The likelihood that you've been exposed to one is likely high. Somewhere between 1/4 to 50% of patients or individuals may have been exposed to any one of the vectors that are being used for these trials, and thus having multiple companies, multiple trials, multiple different vectors involved. And so yes, there are multiple companies, and hopefully, if you're resistant to one, you will be not resistant to another. And then the final question, because it's the last one here, and I sort of have to run as well, is where can you look into joining the home Phe monitor study? Clinicaltrials.gov, or contact the Center for Rare Disease Therapy here. The 2 sites are Boston and Pittsburgh. I'll warn you that this is an NIH-sponsored trial and not a company-sponsored trial. So we have limited ability to subsidize visits for the study. On the other hand, the visits it's a relatively short-term study, and there aren't a lot of visits. So if you can get here, we can certainly enroll you if you're out of town. And we're always looking for opportunities to figure out how to help patients who want to come and enroll. So with that, I guess I'm going to say thanks for being online. If anybody you know has missed this and would like to hear it, it will be posted on the Center for Rare Disease Therapy website, and as soon as that's up there, we'll share the links with anybody who participated in the webinar. We'll also pass it on to CAN-PKU and PKUA, so they'll be able to put it up on their websites. And with that, I'll say goodbye. Have a good weekend. Have a good holidays coming up, and please stay tuned for lots more exciting information on new PKU therapies. Bye-bye.